So it looks like we are live now. Hello, everybody. Welcome at today's webinar about surfactant therapy and LISA-Methode. My name is Christoph Lerle. I'm the business unit manager for neonatal products at Vygon, Germany. First of all, I hope your streaming quality is good. If not, please do not hesitate to log out and restart the webinar. But in general, the software we are working today with is very stable. Anyhow, we expect up to 1,000 attenders from 5 continents, what is quite a challenge even for this kind of software. So if there are kind of problems occurring, so it can be, so log out, dial in again, and it will work, I'm sure. The only continent without any participant from is the Antarctic, as I can see here on my screen. I guess this is okay. This is okay. So once again, welcome at this webinar. Ms. Kribs, our today's speaker, will join us in a couple of seconds. Let us use this time to get a little bit more into detail about the procedure of this webinar. For the whole session, you will not be able to use your microphone or to ask questions or give comments. This has the background with 1,000 participants. It would be quite a mess, as you can imagine. But you can write questions in the chatter. You will find a button on the upper right of your screen. At the end of the webinar, Angela will answer as many questions as possible. One more information, during the webinar, there will be short surveys. So please just choose your answer and click on the button next to it. And last but not least, I'd like to inform you that this webinar will be recorded. The idea is that we will upload it on social media channels. And of course, nobody of you will be named or can be seen in the record. So don't worry about this. And I think now Ms. Kribs should be live. Yeah. Good afternoon, Angela.
Good afternoon.
Thank you.
To everybody.
Angela, we have at the moment, I look at my screen, we have 520 participants from all over the world. The only continent which is not on the table, I would say, is the Antarctic. But I think this was expectable. Angela, do you like to introduce yourself or should I do this for you?
You can do it.
Okay, I do it. It's a pleasure. So Angela is a senior physician at the University Hospital Cologne, here in Germany, of course, and she's one of the leading pioneers and scientists in the treatment of respiratory distress syndrome. Furthermore, she's the co-inventor of one of Vygon's products, our surfcath. And I'm very happy that she will share her experience with us today. Angela, did I introduce you well? Is everything right for you?
Yes, it was very nice. Thank you very much.
You're welcome. Angela, just before we start, I like to do a short first survey about the LISA-Methode, just to get an idea how common this approach is for our participants. Do you mind?
Yes, I agree with you. Do the
Good.
survey. I'm interested in it.
Me as well. So now you should see on your screen a short survey, and it is about the method do you use to apply surfactant to treat respiratory distress syndrome. First of all, you can answer with I use the LISA-Methode, or you use the Ensure method, or none of them, or you give no comment. I think the last possibility to answer is for people who are not physicians in the field of neonatology. So I can see the answers coming. You just have to click in the small white field. Okay, I can see that we have now most of the participants answered. I guess we can now show the results directly. And what we can see is that already 47% are using the LISA method. There are still 1/4, 25% of attendees which are using the INSHA method, and none of them, 8%, no comment, 20%. Okay, quite interesting. I would propose to repeat this survey at the end of the webinar to see if the interest in the LISA method is bigger than before, and if people are willing to change, because I think the LISA method is the currently most popular method because of the good outcomes. Mrs. Kribs will tell us, Angela will tell us more about this. And Angela, now I would hand over to you. I would switch off my screen, and the stage is up to you. Okay?
Yes. Thank you very much. Thank you for the introduction, and thank you for giving me the opportunity to give this webinar today on this very interesting and hot topic of less invasive surfactant application in the therapy of the ERDS of preterm infants. I want to start with the background. Please give me my slides.
Yes, one moment.
Yes. So first of all, I will declare my possible conflict of interest. I was a co-investigator of the surfcath. That's why I'm speaking today here. But also during the last 5 years, I received honoraria for presentations and travel support from Chiesi Farmaceutici and from the Medela company. Before I want to speak about the LISA-Methode, we have to keep in mind is that the association of surfactant administration and mechanical ventilation is mainly a historical phenomena. When surfactant was introduced into the therapy of RDS of the preterm infant in the 1990s, most of these premature infants were already ventilated based on other causes than lack of spontaneous breathing. Nowadays, most babies are born and come to spontaneous breathing after birth. We have to know that an endotracheal tube inactivates the laryngeal function, and mechanical ventilation via an endotracheal tube has a risk to induce lung injury and may perhaps also influence the development of brain lesions. Mechanical ventilation, therefore, should be avoided whenever possible. But given the association of surfactant administration and mechanical ventilation, this means that surfactant is withheld. But on the other hand, surfactant, usually related to intubation and mechanical ventilation, has improved the prognosis of preterm infants more than any other therapy. I already mentioned that most preterm infants start spontaneous breathing after birth, and therefore they do not obligatorily need intubation and mechanical ventilation. And nowadays we know that the spontaneous patterns of breathing immediately after birth are important for lung recruitment. And during this process, larynx plays an important role. And therefore the inactivation of laryngeal function by intubation with a big tube is a risk. CPAP as primary respiratory support has an advantage to preserve laryngeal function and to facilitate thereby lung recruitment. And CPAP as primary respiratory support is a safe alternative to intubation and mechanical ventilation. Given all these facts, we see a dilemma. The outcome of extremely low birth weight infants treated with nasal or pharyngeal CPAP as primary respiratory support is comparable to that of infants treated with primary intubation, mechanical ventilation, and surfactant administration, but is usually related to withholding of early surfactant. On the other hand, I already mentioned surfactant has improved the prognosis of preterm infants more than any other therapy. So surfactant without any mechanical ventilation, but with CPAP-supported spontaneous breathing could be the combination of two highly effective principles. Nowadays, we have big evidence for the efficacy of early and CPAP versus intubation. During the last decade, there were 3 big trials, including in the whole more than 2,000 infants, comparing early nasal CPAP versus intubation and surfactant application. And in all these 3 trials, we saw similar effects of nasal CPAP compared to mechanical ventilation, but no advantage in the group of babies ventilated and having received surfactant. And it's important to notice that no baby in this CPAP groups received surfactant. We know that a lot of babies with very low gestational age need surfactant during the first days of life. Also, the babies who start with CPAP are intubated later to receive surfactant. That's called CPAP failure, and CPAP failure is very often in babies with a gestational age of 28 weeks or less. And as you see on the picture in the right corner, CPAP failure is related to high mortality and morbidity, and so far CPAP failure should be avoided. We need urgent strategies to reduce CPAP failure. And one of those strategies could be the application of surfactant. That's why already 30 years ago, the group from Henrik Werder investigated the so-called INSURE procedure. INSURE means that the baby is only intubated to receive surfactant and extubated immediately after the application of surfactant. But also, INSURE is related to intubation and ventilation, at least for a short time. And the already established spontaneous breathing on CPAP is disturbed by the act of intubation and a short ventilation. Therefore, there is an ongoing search for even less invasive ways to combine the benefits of surfactant and CPAP. On this slide, you see the development of such strategies. The oldest of these strategies is to apply surfactant in the pharynx of the baby immediately after birth. That was already investigated in the 1980s by the 10th Center study group, but the group was not successful in showing any benefits. In 2004, Katwinkel and his co-workers did a further study comparing the application of surfactant into the pharynx to CPAP alone. And they saw some effect in babies who were delivered spontaneously. And there is actually a big study going on to compare pharyngeal application of surfactant to CPAP alone. More recent trend to give surfactant non-invasively is the administration via a laryngeal mask, but this is limited to babies with a birth weight above 1,500 grams. The really non-invasive or the way to give surfactant without any disturbance of the baby would be aerosolation or nebulization of surfactant. But this is very complicated and has many technical reasons that it's not successful. So the thin catheter administration is the recently most investigated approach. It was firstly described by Werder and his colleagues in 1992, but the colleagues in the Scandinavian countries could be not convinced that this is the right way to give surfactant. They were convinced that surfactant has to be moved by positive pressure into the lung. And so the idea of Werder was further developed to the Insure method. But the Insure method has the problems I already talked about. And so in the early years of this century, we started in Cologne to investigate the original approach by Werder to give surfactant via thin endotracheal catheter during CPAP-supported spontaneous breathing. And now I will speak a little bit about the evolution of this method and about the evidence that is available nowadays. In general, less invasive surfactant administration via thin catheter is shown in these pictures. The principle is placing a thin endotracheal catheter by direct visualization of the vocal cord. And in our approach here in Cologne, we use a Megel forceps to place the catheter into the vocal cord. After the placing of the catheter, surfactant is given via the catheter, and during the whole procedure, the infant is breathing spontaneously with CPAP. This approach was modified by Dargarwell and his colleagues, and they used a more rigid vascular catheter, and therefore in this approach a Megel forceps is not necessary. These are the results of our first feasibility study in Cologne, and we included a historical control group of 34 infants and compared them to the infants born in the observational period where the new approach was available. We could show that during period 2, the mortality in infants below 27 weeks was reduced, and we observed less IVH bigger than grade 2 and less pulmonary interstitial emphysema. Based on this promising results, we introduced this method in our routine care and did close observation of the results. And we could observe during the first 4 years of using this method that we reduced CPAP failure. And along with the reduction of CPAP failure, we observed also that infants who were successfully treated with CPAP alone or CPAP with surfactant had comparable results, whereas babies who had CPAP failure or who had to be intubated immediately after birth had worse results. We could show that CPAP failure was reduced and that we had, along with that, a reduction of BPD, of pneumothorax, and of IVH higher than grade 2. Along with this observation, we did a further observation that is very important if you want to introduce the method in your unit. On this picture, you see the cohorts of infants with different gestational age. Cohort 1 are infants with a gestational age of 23 and 24 weeks. Cohort 2 are infants with a gestational age of 25 to 27 weeks. And cohort 3 are babies with a gestational age with more than 28 weeks. And what you can see is the survival without BPD and the survival without any major complication of premature birth. And you see that with introduction of the method in the first year, we saw a big increase of survival without BPD, and survival without any complication. But after the first year, we saw that the results become a little bit worse. And thus, this was related to the fact that more clinicians used the method. That means that each clinician has to learn the method, and we have a learning curve concerning the results of the success of the method. That is something that you have to keep in mind if you introduce the method in your unit. After our first observations at our clinic, the method spread very fast in Germany. And so we had the opportunity to analyze the data in our German neonatal network. And we could see that in the German neonatal network, our first observational data at the single center could be confirmed in a multi-center setting. Outside of Germany, the colleagues in Vienna, Austria, were the first who introduced the method in their unit. And also they observed the same effects as we had seen in our first feasibility study. Also in their group, they could reduce the mortality and the rate of major EVA, the rate of mechanical ventilation and pulmonary complications. At the same time, at the other end of the world, Peter Dagerwell and his colleagues investigated the approach with the rigid vascular catheter that I mentioned at the beginning of the talk. And they also observed an improvement of the outcome of the babies. And they also showed the effect immediately after the application of surfactant. They saw that the FiO2 could be reduced after the application, that the CPAP pressure could be reduced, and that at the same time the SpO2 increased. So from a lot of observational studies, there was certain evidence for the effect of less invasive surfactant application, and this was followed by some prospective randomized control trials. And the consistent findings of the observational studies were a decrease of FiO2 and distending pressure after the procedure, less need for intubation during the first 72 hours compared to historical controls, and trend to shorter duration of different kinds of respiratory support, and especially in the most immature infants with a gestational age of less than 26 weeks, lower mortality, less IVH, and less ear leak. There were also consistent findings of side effects. The need for more than one attempt to be successful was between 10 and 25%. The need for positive pressure ventilation via mask after procedure was between 20 and 45%. There occurred also desaturations and bradycardias in 10 to 35%, and the catheter could dislocate, or the surfactant could reflux from the trachea. But all side effects could successfully be managed with ventilation via a face mask. As I mentioned, until now, there were 6 prospective randomized controlled studies, including in the whole nearly 900 patients. And these are data from a meta-analysis from Rigo et colleagues from the year 2016. And you can see that with the use of less invasive surfactant application, a lot of parameters could be improved, especially parameters related to pulmonary outcomes such as BPD and mechanical ventilations. But there's also a trend to less IVH and less NEC. You see that there are procedural complications like coughing and surfactant reflux, but they can very good be managed. Similar results are also observed if you compare the method only to INSURE, like is shown in the first block. These are 4 studies, and also with INSURE is the comparison to INSURE. Less invasive surfactant application can reduce death or BPD and early and CPAP failure. This is a highly interesting study This is a network meta-analysis where different kinds of approaches of non-invasive ventilation strategies are compared to each other. And the principle is that the different modes are simultaneously compared and the effect quantified in comparison to each other method. And if you do this analysis, the authors could show that LISA was superior to mechanical ventilation. It was also superior to NCPAP alone. It was superior to Insure and also to NPPV or laryngeal mask concerning the outcome bronchopulmonary dysplasia or death. This leads to the recommendation in the European Consensus Guidelines on the Management of Respiratory Distress Syndrome that LISA is a preferred mode of surfactant administration for spontaneous breathing on CPAP, provided that clinicians are experienced with this technique. And that's why I want to speak about the use of LISA in the different countries. And I want also tell you something about our experience and about the facts you should know if you want to introduce LISA in your unit. This is a European perspective on less invasive surfactant administration from the year 2017. You see that in this survey, the percentage of centers using LISA increased since 2010, 2011. That was a time where the first study, prospective randomized controlled study, the AMV study, was published. But you see also that not all neonatologists are convinced that the efficacy of LISA is very high. The study or the survey included 37 countries and 160 participating centers, and 52% of the participating centers were convinced that the efficacy is high, and 30% said it is very high. But there were also 33% not so convinced that the efficacy is high. This is a survey in the Scandinavian countries where Insure was very public since the 1990s of the last century. And you see that there are big differences in the different countries of Scandinavia, whereas in Iceland, all participating centers used LISA. The rate was very low in Denmark or in Sweden, where people are used to use the Insure procedure. In the US, the situation is very different. Most neonatologists do not use LISA. These are 85%, and only 4% use it regularly, and 4% sometimes, and 7% only as part of research study. So there are big differences over the world, and I think it's important to see or to talk about some practical aspects of the LISA method. If you want to use LISA in your unit or in an individual infant, you should meet some organizational requirements. It should be possible to intubate the infant if it is necessary. LISA should not be performed if there is no possibility to intubate and ventilate the infant as rescue. You should have the opportunity to monitor the infant, so you should have every instrument you need for intubation and ventilation. And it's very important that clinicians who perform the procedure are experienced with the endotracheal intubation of preterm infants. And if you perform LISA in an individual infant, the infant should be monitored for SO2 and heart rate. It should have a gastric tube and a venous line inside. The baby should be on stable spontaneous breathing with CPAP, and the baby should have a stable circulation. And it's very important to have in mind how we can influence the stability of the baby after birth. The anesthesia of the mother can influence the stable breathing of the baby. The volume state can influence the circulatory stability. That means that the blood volume of the baby has to be optimized by late cord clamping or cord milking. The content of lung fluid depends on some factors we can also influence, such as the application of antenatal steroids, and it depends also of the mode of delivery. The suitability for LISA, expressed by the stable spontaneous breathing and the stable circulation, can also be influenced by infection, asphyxia, or by stress during the primary care at the delivery room. So there are some measures we can perform to reach suitability for LISA. We should have and establish a strong cooperation with the obstetricians, midwives, and anesthesiologists. The mother should get antenatal steroids. We should avoid an infection or birth asphyxia. The anesthesia of the mother should be done with consideration of the infant's need, and the baby should receive any kind of placental transfusion by late cord clamping, cord milking, or physiological-based cord clamping. It's also very important to have a standard protocol for the postnatal stabilization with rules for the titration of FiO2, CPAP level, or use of positive pressure inflations. You should avoid any stress for the baby, and you should keep in mind that any touch means pain for the preterm infant, and pain disturbs the rhythm of breathing. So it's very important to stay calm and to disturb the baby as less as possible. And in Germany, it's already widespread use to give caffeine already during the stabilization in the delivery room to stabilize the spontaneous breathing of the baby. This slide showed I already at the beginning of the talk, and this slide shows the risk factors for CPAP failure. I showed this slide with a focus on the morbidities and mortalities showed on the picture, but now I want to focus your attention on the upper part of the slide, and in this part you see that for babies with a gestational age of 25 to 28 weeks, the gestational age and the mode of delivery, as well as the FiO2 by 2 hours and the CPAP level by 2 hours, determinants of CPAP failure. So if you want to decide which patients need LISA, you have to look on this whole situation and to look of whether the baby is on risk for surfactant deficiency by gestational age, gender, or the absence of antenatal steroids. Besides this, you should observe the FiO2, the CPAP level you apply. And in our unit, we use a Silverman score to quantify the dyspnea of the baby. And I'm convinced that this score is a favorable tool to decide whether the baby needs surfactant. We have developed for our unit an algorithm how we stabilize the baby on spontaneous breathing by increasing CPAP level, increasing FiO2, and then stepwise reduction of these two parameters. And at the end of the stabilization, if there is no change anymore, we decide, depending on Silverman score of FiO2 and of CPAP level that we use, whether we can stop CPAP. We have a high probability that the baby can be stabilized with CPAP alone, or whether the baby needs surfactant. And if the baby has a Silverman score of more than 5, or a FiO2 higher than 0.3, or if we need a flow, and that means a CPAP level of more than 12, we apply surfactant. How do we give surfactant? We position the baby on his back. We hold the baby in facilitated tucking. We prepare the catheter with a syringe filled with surfactant. Then we visualize the vocal cords by direct laryngoscopy. Then we put the catheter into the vocal cords. We fix the catheter with 2 fingers. We close the mouth of the baby, and then we give surfactant. The speed depends on the breathing effort of the infants. And after the procedure, we do an aspiration of the gastric tube to confirm right application. We do LISA in the very immature infants without pharmacological analgosydation. We do non-pharmacological analgosydation by facilitated tucking. How you see it on the picture, the baby is holded. The baby gets something to suck. In the ideal case, we have some drops of colostrum already possible to give to the baby, and we talk to the baby so that the baby becomes very, very calm before the start of the procedure. In more mature infants, we also do pharmacological sedation, and we use ketamine with 1 milligram per kilogram to perform the procedure. On these pictures, you can see the course of the SO2 and the heart rate during the initial stabilization and the surfactant application. In the upper left corner, you see an application with ketamine, and in the lower corner, you see an application without ketamine, and you see that there are no big differences. In any case, we have a slight drop of heart rate and of saturation, but with a very rapid recoverment. Practical question is what catheter should be used, and on this picture you see in a recent publication by Egbert Herting the available catheters until the last year. You see the endotracheal tube, umbilical catheter performed by Chiesi companies, and an application aid that are all available on the market. And now we have a further catheter that is a surfcath from Vygon that was developed in cooperation with our unit. This catheter has black blunt distal tip that minimizes tracheal lesions and has a good visual mark to address the inserted length. This is another view of the catheter. This is how you have to place the catheter into the baby's mouth and how you can apply surfactant. And now I want to show you a short video where we use this catheter to give surfactant. Du hältst hier die Beinchen mal hoch. Das ist einfach einzuführen. Da ist sie. Aber sie macht sie nicht auf. Ich habe hier den Fehlkopf, aber da, jetzt ist es. So. Draufsetzen. Und jetzt spritzen wir ganz langsam, damit sich erst erholen. So. Gut. So, Schätzchen. Das war gemein, ne?
I have a quite practical question from Kribs. So our colleague from Kribs is asking, how deeply do you introduce the surfcath? I guess he means how deep does the tip goes behind the vocal cords?
That depends a little bit of the gestational age of the infant. The smallest infant of less than 28 weeks, we insert it 1.5 centimeter, and in the bigger infants, 2 centimeters.
Okay, quite interesting. So I think the tip is around 2 centimeters. So yeah, this is a good indicator for the depth of the placement. I have a kind of, I would say, a little bit a critical question, but critical questions should be asked, I would say. And it is, Angela, is there an increased risk for pneumothorax with the LISA method? What can you say about that?
No. No, we can say that that in our unit, after the introduction of the LISA method, the rate of pneumothorax decreased. I think that's very important to give surfactant also with the LISA method early in the course of RDS, so that you get not the development of hyaline membranes. And if you give surfactant early in the course of RDS, before you have hyaline membranes and inhomogeneous ventilation of the lung, then you have no increased risk of pneumothoraces. And we see nearly no pneumothoraces with babies who receive surfactant via LISA early in the course of RDS. We see pneumothoraces in babies who are under the limit to get surfactant. They are without surfactant on CPAP, and they fight a little bit to struggle with respiratory distress, and these babies are at risk for pneumothorax. And if you give surfactant late, then you have perhaps this risk of pneumothorax, but it's not related to the LISA method.
Thank you. That was a quite clear answer based on your experience. Another answer or another question which was asked is, it is coming from Austria, I guess. Yeah, it was Austria. Angela, can you tell us which studies on the respiratory distress syndrome are currently underway in Europe?
I know that we will have a study of prophylactic surfactant application in babies below 28 weeks that will be funded by the German Ministry of Research. I know that all over the world there are some studies with surfactant applications via a laryngeal mask. I do not exactly know whether there are some ongoing studies about LISA with a catheter.
Yeah, thank you very much. Interesting. I just have to ask my colleague who's sitting next to me and is following the chat if you have other questions. Yeah. Yes, we have some other questions. Oh, from the Philippines. Nice. I just read it. Can we give oral caffeine even if the patient has not started feeding or has not reached full feeding? So the question is, can we give oral caffeine even if the patient has not started feeding?
I cannot say it. We do not do it. I do not know whether anybody has experience with it. We give caffeine orally only if the baby has started. But we start feeding during the first 24 hours, and we give caffeine orally at the second or third day. But at the first day of life, we give it intravenously.
Mm-hmm. So it looks like we get an answer on another question in the chat. Maybe it's an answer on the question if somebody is using or applying caffeine even before the patient started feeding. So I just have to wait a second until I get the question handled by my colleague or the remark which is given in the chat. Maybe in the meantime, I would put another question coming from Germany, from Bavaria exactly. It's coming from Bavaria. So, do you use a video laryngoscope for the surfactant administration with surfcath? Because we have the problem, it's kind of bulky. What do you think? Do you think it's useful to do it?
We do not do it, but I think it could be useful, especially with view on teaching. I tell to you in my talks that there's a learning curve for each individual clinician, and so it could be useful to observe the trainee with a video laryngoscope. So it could be useful, but I have no experience.
Okay, thank you. Yeah, it seems to make sense for the learning curve. It could be quite helpful, maybe. I get another question or a remark. No, it's more a question, I would say. It is coming from the US. Does the rate of delivery of the volume of surfactant have any impact on the outcome with LISA? So it's about the speed, how fast you give the surfactant, and does this speed, I would say, keep it simple, have any impact on the outcome?
I think it depends on the preparation of surfactant. Here in Germany, we have experience with 3 surfactant preparations with Alveofact, Curosurf, and Surfactant, and to my fast, because it's a very little volume, and the substance has a very high spreading. With Surfactant, we should give a little bit more slowly, because the volume is higher, and the preparation is not spreading so fast. So I think it depends on the preparation, and you should make your experience with the individual preparation. I think if some synthetic surfactant is coming into the market, we have to observe very cautious how fast the speed of the application should be. I think that makes perhaps a difference what preparation you use.
Thank you, Angela. Thank you. So here's another question, also more practical, I would say. It is coming from a European country. It is coming from Poland. So which pressure do you use for lung recruitment? I think they mean the PEEP. Which pressure do you use? We
start with a PEEP of 8 to 12 centimeters of water seal in the delivery room. The younger, the more immature infants get higher PEEP at the start. Then we increase the PEEP every 30 seconds until the baby starts stable breathing, and we go up to levels like 20 centimeters of water seal. And then if the baby breathes stable, we reduce the PEEP every 30 to 60 seconds down to a level of 8 to 10 centimeters of water seal.
Thank you. This was quite clear, I guess. And now I get the next question. One question after every time I get a new question when I look at my colleague. So how do you deal with the potential surfactant loss due to reflux or due to the dead space of the syringe?
Due to the dead space of the syringe and the catheter, we fill the syringe with air and give a volume of air to clear the syringe and the catheter from surfactant before we take the catheter out of the trachea. And if they have some reflux, we observe the baby, and if necessary, and if we see no success of surfactant application, no decrease of FiO2 or CPAP level, then we give a second time surfactant to give the volume the baby needs.
Okay, good. Thank you. I guess we come to the last question now. I think it's a little bit a question we already tried to answer, but I will repeat it anyhow. How quickly do you give the surfactant?
At the moment, we use only CoralSurf in our unit because it has some economic reasons with our pharmacy. And as we use only CoralSurf, we give it quickly. That means 30 seconds to 1 minute.
Mm-hmm.
But as we used the Ranta, we needed 1 to 3 minutes. It depends on the volume and on the preparation you use.
Okay, thank you for these answers. So I can see no other questions in the chat right now. Also, I get no new papers from my colleague sitting next to me. So Angela, maybe you like to say some final words to our attendees, maybe?
Yes, I would be happy if you stay interested in the LISA-Methode. I'm convinced that's a promising approach, but I also know that there's a big need of research, and I would happy to have big number of clinicians who are working together to improve the method further.
Thank you, Angela. Angela, also from my side, I like to say some final words. Once again, thank you for this outstanding presentation. I also like to thank my Vygon colleagues, Christelle Tommy, Susi van der Loo, and of course my colleague sitting next to me, Julia Opladen, for their support on this project of webinar. And last but not least, I like to thank all participants. Thank you for joining us. I hope it was interesting for you, and maybe we see each other at the next Vygon's webinar. Anyhow, have a nice day. So goodbye and greetings from Germany. Miss Kribs, Angela, thank you very much once again, and see each other, I hope, quite soon. Goodbye.
Goodbye.